Perfect. I hope everyone's
Yeah.
back. All right. So, guys, welcome to the Respiratory Revision lecture. Before I start off, the GI one was amazing, actually. I learned so much from it myself, to be honest. I don't know, does that mean if I paid attention in second year or if those were just really good? I think they were really good. Firstly, my slides are kind of old man like. They're not like as pretty as theirs. So sorry about that. So the coolest thing about my slides is literally just that image, which highlights like the tracheobronchial tree. So just a couple of basic stuff before we start the lecture. So it's like housekeeping. How are you going to be approaching rest for the exams and in general? Then anatomy and physiology, because they make up quite a big chunk of your exams. Then pharmacology combined with micro, and then clinical skills through questions, pretty much. So look out for the red notes that I've put in. I'm not gonna lie, I kind of got lazy after anatomy with this, so I'll just let you know when stuff's important. But the red notes are meant to show you what stuff's important. It's an interactive session, so like feel free to like turn off your mic and ask me questions, or if you just want to like ask questions in chat, go for it. I may not be able to reply to the chat straight away because it's just me running the presentation. But the minute I see a notification, I'll try my best to answer it straight away. So in this session, you'll see me going back to the same stuff over and over quite a few times. And it's because like your whole body's connected and you kind of keep going over stuff and like it all interconnects. Finally, don't get too stressed if you don't know something, because I'm going to explain it to you again if you don't get it. Also, I'd like to give a shout out to Google. PS, I miss Preclin. It's run by someone in the year level above. PS Papa and PS Pingu, who run PSP for you guys, and Armando's channel for with the presentation, because I actually don't make any notes myself. So it's like a collation of a lot of other people's stuff. And after this presentation, if you have any questions regarding respiratory or any secondary like related stuff, just message me on Facebook or shoot me an email. Here's my details. You guys have the slides anyway. So starting off with rest, by now you should realize that you should be studying systems based, because it makes your life so much more easier, because it allows you to create links between stuff. So think about it, like start off with anatomy, get like a gross understanding of like the bigger structures, and then start learning the final details about them. Like think about the thorax, the lung, the airways, and then little details about them. Then go on to the physiology and like ask yourself, what does that anatomy do? How does it exchange the oxygen, and how that oxygen is transported around the body, and how all of this is controlled. Then think about the different pathogens that can affect our body, like that can invade our body, and how our immune response reacts to them, or how our immune response does stuff in general. Then in clinical skills, like think to yourself, why are we asking these questions in the history? Like, or why are we doing these things in the exam? Like if you heard a friction rub in the exam, in the respiratory exam, you'll be like, okay, so they were having a problem between the two pleura. So there was a rub, so there was friction. Probably it's pleurisy. If you had fine crackles, that means there was some sort of fibrotic change there. So maybe you're leaning towards more ILD. So like those little things of why you're hearing those things, of why you're asking those questions, can actually help you connect a lot of the stuff. And finally, some pharmacology at the end to see how you can fix the problem that you finally diagnosed. Now, starting off with anatomy. So this image over here highlights it quite well. So think of like an air particle. It goes through your nasal cavity, then it goes through your paranasal sinuses, then you have your pharynx, and then the portion of the larynx above the vocal cords or the epiglottis. That's your upper respiratory tract. That's something that's going to be covered in head and neck next semester. The focus of this semester would be the lower respiratory tract, which includes the larynx below the vocal cords, the trachea, then the bronchi. You have your primary bronchus. Then I'll get into that in a second. After the bronchi, it gets into bronchioles. And then you finally have this little alveoli. And then I'm going to be talking about the lungs after that, because once that oxygen from the air, that air particle has gone all the way through in the alveolar sacs, it gets exchanged and goes into the blood. And then from there, it goes everywhere else. what happened here? Yep. I don't know what's happening to my presentation, but sorry. All right, so the pathway of that air molecule, just in a bit more detail. So we'll go through the trachea, then it will go through the left and right main bronchus, which is your primary bronchus. Once it's gone to either of the two lungs, then within each lung, it will go into a particular lobe. And that's when it becomes your lobar bronchi or your secondary bronchus. Within lobes, you have further bronchiopulmonary segments. And then that's your tertiary bronchus. It's going to get further divided. Then those tertiary bronchus or those segmental bronchuses bronchi are going to become bronchioles, conducting bronchioles, and then they're going to become terminal bronchioles. And this is your conducting zone. This is where the air travels from the outside world to the inside of you. And along the way, it gets humidified and gets brought to a proper temperature. After that, you reach the respiratory bronchioles. This is the part where you actually start breathing now. This is the respiratory zone. Respiratory bronchioles, alveolar ducts, and alveolar sacs. These images highlight this quite well. You would have also done something in embryology which goes along these lines. The main parts of those things I will be highlighting in the next couple of slides. But what you need to know is after this terminal bronchioles, you have this transition zone, and then you have respiratory bronchioles. So in the pathway of the air, in the trachea, the important things you need to know, it bifurcates at the level of the sternal angle, T4 and 5. This is also called the plane of Louis. And I have a full slide dedicated to it afterwards because they're probably going to give you a question about this or the anatomy stuff. The trachea is a cartilaginous structure. And this is important for a more histological point of view when they give you like histo slides, like remembering what stuff has cartilaginous. And an easy way to remember this is everything above the terminal bronchioles is all cartilaginous and everything below is non-cartilaginous. It's like kind of like flaccid in a way, and it's just like held together by cells. So now moving on to the primary bronchus, the main point is the right bronchus is shorter, wider, and vertical. So it's shorter, wider, and vertical. So pretty much what it means is if you have a kid or if you have anyone and you like accidentally inhale something, an object, which is called an aspiration, it's going to go to your right lung. And then based on how you like either standing, lying down, or on your right side, it's going to tell you which segment of the lung, of the right lung, it's going to go to. So there's like plenty of segments of the lung. There's 10 bronchiopulmonary segments on the right and 8 on the left. You don't need to know the individual ones. All you need to know is for the base on how stuff gets lodged in them. Like if you're standing up, it's going to go. So if you're standing up, it's going to go to the right lung on the inferior, on the basal part. So it's going to be the posterior basal segment of the right inferior lobe. So this is a bit of memory work, actually, I'd say. If you just memorize it, it's going to probably give you a mark on the exam because they're probably going to ask you about aspiration because Michelle Lazarus loves talking about this over and over. Now, moving on to the bronchi, I've already touched about this, like your lobobronchi next, then you have your segmental bronchi. Now, this is the part which is now the changing part, which is your terminal bronchioles. It's a part of that little transition conducting zone area where you don't have cartilage in the walls anymore because you're now becoming a bronchiole. And then you have your respiratory bronchioles after that. These are seen by the 25th week of gestation. This is the only important part apart from pleura, from embryology that you need to know about. The rest of it you can all ignore about embryology. I don't know how much detail you guys go into, but we didn't go into that much detail. So that's why I only put that much in there. Now from the respiratory bronchioles, you move on to the alveolar ducts. They're pretty much ducts lined by alveoli. And then when there's a lot of alveoli collected in an area together, they become an alveolar sac. This is the alveoli is a site of gas exchange, and it's lined by simple squamous epithelium. And this histology buzzword is pretty important. Like simple squamous epithelium means you're at the alveoli. That means you're at the ducts or the sacs. And then the alveoli is made up of 2 types of pneumocytes. You have your type 1, which is responsible for gas exchange. If you can notice the blood vessels surrounding them, it shows you that they're responsible for gas exchange, and they span quite a bit of the area. And then type 2 is important for surfactant. This is this chemical that helps the alveoli to stay open. I'll touch back upon this later when I'm going through physiology. While we're in this area, might as well see what happened to that air molecule that came in all the way from your nose and now into your bloodstream. So first it touched that surfactant layer, then it went to the type 1 alveolar, a type 1 pneumocyte. From there, both type 1 and type 2 pneumocytes are on a basement membrane. It goes through that. Then the endothelium of the blood vessel, then the plasma, and then finally like a red blood cell within the blood vessel. Now let's talk a bit about the gross lung itself. So there's two lungs, a right and a left lung. So the right lung is shorter and wider, but it has three lobes: a superior lobe, a middle lobe, and an inferior lobe. And the left lung only has a superior and an inferior lobe. Now, this aspirated material stuff that I mentioned before, this comes twice in your like dot points in anatomy. So that's why I was saying that it's important to memorize these, because they're probably going to show up on the exam. Now, the left lung is narrowed to accommodate for the heart. And there's also a name for this thing called the Costo mediastinal recess. There's a recess over here as well. And that's regarding the pleura in the area. Now, hilum, this is where it's like entry into the lung. So it's basically the thing that you need to know here is the relation of the pulmonary arteries in regarding to the bronchus. So there's this mnemonic called RAILS, which says right hilum, they're anterior, in the left hilum, they're superior. And the clinical relevance here is if there's symmetrical bilateral hilar enlargement, you have sarcoidosis. But if it's only asymmetrical, it's cancer. Could you guys pop up in the chat saying what lung this is? I've also marked like superior, anterior, and posterior for you. Yeah, there's a right lung. So there's two ways to tell about this. Either you can use your rail system to be like, all right, the pulmonary artery is anterior to the bronchus, or the other way is saying that there's three lobes in the area. So there's two ways about the same thing. Now, moving on, the next thing is the surface anatomy. Now, for the surface anatomy, in this surface anatomy picture, you can see that the right lung is separated by two fissures. There's this fissure called the horizontal fissure, which is unique to the right lung, which separates the superior from the middle lobe. And then both sides have an oblique fissure. The oblique fissure helps separate the inferior lobe from the other lobes. That's how I try to remember the two fissures. Oblique fissure separates inferior from everything else. Horizontal separates superior from middle. And in the lung, there's another two important areas here, which are the recesses. So there's a costo mediastinal recess. It's over here. And then there's a costo diaphragmatic recess. My bad. Sorry about that. And then there's a costo mediastinal recess, which is in this like hook where the cardiac notch is to accommodate for the heart. These two are places where fluid can collect, and that's why these are clinically relevant. But these areas are formed by something called the pleura and like the leftover space between the two pleura. Now, this is really, really high yield stuff. So with pleura, what you need to think about the fact is when you had gestation started, you had this area in your body for the lungs, and you had this windpipe coming in. Yeah. Now, originally, this was all one big thing, and this comes from the inside of it, and then it grows out into the outside of it. So it's one continuous sheet. This concept of it being one continuous sheet, once you get your head around it, it's so simple. Once you have your head around it, you'll realize that the visceral pleura is the one that's on the lung itself. And because it's on the internal organ, it only is sensitive to stretch, and it has a very poor like localization of pain. But then there's an area between the lung and then the lung cavity, like the one that surrounds the lung cavity, not the lung itself. That's called the parietal pleura that you can see in the red over here. This is the one that senses pain, pressure, temperature. And in this, you get pain based on what area of the parietal pleura the problem is in. Like, if is it in the cervical area, the costal area, the diaphragmatic area, or the mediastinal area. So that's the important distinguishing between the two things. The point where you go from the visceral pleura to the parietal pleura, which is over here, is called the pulmonary ligament, as you can see over here. And this is what it shows, that it's one continuous sheet. Now, between these two pleuras, you also have like a space, like a pleural space. And in this pleural space, you have pleural fluid. Or I think they call it parietal fluid actually, but pleural fluid, parietal fluid, you can call it either of the two. It's pretty much the same thing. Now, the importance of this is the space between them two is what forms the recesses. If you have water collecting in this region over here, like in the corner, and you get a blunting of this costophrenic angle, you have a pleural effusion. If you have some sort of trauma there and there's now air between the two pleural spaces, you get a pneumothorax. If you have blood between the two spaces, you get a hemothorax. Now, before I move on, I hope if anyone has a question about this, you can feel free to ask me, because there will definitely be quite a few questions about the whole pleural spaces, like parietal and visceral pleura and all that. Now, the next thing moving on in this of clinical relevance is the different lines and the different foldings of the visceral and parietal pleura. So in the mid-clavicular line, the visceral pleura is at T6 and the parietal pleura is at T8, which you can see in this image. At the mid-axillary line, which is going to go on the side over here, is at T8 and T10, which helps you form your costophrenic angle. And on the back side, you can have the mid-scapular line, which is between T10 and T12, which you can see over here. Now, these three lines where the folding of the visceral and parietal pleura, like the spaces between them, is important, because if they ask you where you want to insert a thoracostomy tube, which is like a tube that helps you like equal out pressures inside and outside of the lung and helps you get rid of a pneumothorax, you're going to have to say, all right, it's going to be in the fifth intercostal space in the mid-axillary line, because you have space there. Like things like that, buzzwords like that are quite important to remember. Now moving on, you have the diaphragm, which is this big muscle that helps you breathe. And it's the one that helps your lung inflate like a balloon, if you can think about it. So it's innervated by the phrenic nerve. C345 keeps the diaphragm alive. And another buzzwordy thing over here is the openings of the diaphragm. They love asking about this. It's like, oh, what leaves at T8? What leaves at T10? What leaves at T12? And they're going to have a bunch of things, but the major ones that you need to look out for is vena cava, esophagus, and aortic hiatus. So the letters in the word themselves show their level of exit. It's like a little mnemonic, like 12 letters, T12, 10 letters, T10, 8 letters, T8. Now, a couple of other knickknacks about anatomy. Yeah, I think my diaphragm picture got cut out for some reason. I don't know what happened there, but I'll insert a diaphragm picture in the post slides for sure for you guys. Now moving on, some other related stuff that's important, that's like a bunch of knickknacks, is when you're inserting a needle in the intercostal space, always tend to be more inferior, so you don't hit the intercostal arteries, because it's better to hit the collateral vessels than hit the intercostal vessels. So remember, always be a little bit like err on the side of a more anterior to a rib or superior to a rib than inferior to a rib. The next important one in this area about bones is your chest wall deformities. Now, if they say someone has a barrel chest, it's pathognomonic for like COPD. Then the other two ones are your funnel chest or pectus excavatum, where like the sternum is pretty much pushed inside, and pectus carinatum, which is like the chest wall looks like that. It's like called a pigeon chest. These ones are not very pathognomonic, but these are just like chest wall deformities that you should be aware of. So the slide said to intend to insert more inferior to this rib. Let's say if this is T4 and T5, you want to insert more inferior to the T4 rib in comparison to the T5 rib. So that's what this that's saying in the slide there. Now at the T4-5 plane, there's a couple of things that happen. You have the angle of Louis, so your second rib costal cartilage, your arch of aorta, your tracheal bifurcation, your pulmonary trunk bifurcation, ligamentum arteriosum, azygous vein emptying into the SVC, your left recurrent laryngeal nerve loops around the aortic arch. So if this gets impinged, you get your hoarse voice. Then your thoracic duct from this point moves from the right to the left and empties into the subclavian vein. And it's the separation of your superior and inferior mediastinum. Now, here's a couple of chest x-rays for you guys. Can you guys type in your answers for these? One of these is actually from a past exam, the second one, pretty sure. Yep, and the first one, the one on the left. Okay, so the first one is a bit of a bad x-ray, but it is there in your anatomy book. Actually, it's from the anatomy manual. And so the second one is pleural effusion, pretty straightforward. You can't see the costophrenic angle, easy. The first one is aspiration pneumonia. So if you pick pneumonia, you were right, because you see some sort of like, you can see a bit of consolidation there. So you know it's some sort of pneumonia. Obviously, I can't tell you the cause from this, but this was an example of your aspiration pneumonia, where they would have given you a stem and they would have been like, oh, this person was standing upright and then they inhaled the coin. Obviously, coin you could see in this case because it's you can see it on a chest x-ray, but something that you can't see, like a plastic toy or whatever. So that this is a chest x-ray of someone like inhaling a little plastic toy or a plastic coin. Now, I know it's a pretty bad x-ray, but it is from your anatomy manual. Now, moving on for histology, I would say check out P.S. Pupper's slides for this, because I personally hate histology, but they did a very good job of like explaining it. The couple of key points that I want you to look at from these ones here is this whole cartilage thing that I was yapping about was like here. See, the bronchus has hyaline cartilage. Now, for me, I always just thought these were like a bunch of pink blobs. So this type of stuff helps me remember what's what. Like this is a cartilage. Because trust me, like in the exam, your brain would be like, oh, is this an intestine? Like, trust me, your brain can work in very different ways. The next one over here is a type 1 pneumocyte. The reason why I'm trying to show this image is this cytoplasmic extension. This is kind of like one of those key things for a type 1 pneumocyte that you won't see in a type 2 pneumocyte. And also the fact that it spans quite a bit of the alveoli as well. And this little layer on top that you see right here is surfactant. But that's my 2 bits of histology, which I think P.S. Papa will do. Their slides did a very, very good job of explaining this in like 7-8 slides. Oh. I don't know what happened to my thingo. Yeah, sorry, this is the part where you get excessive hand movements now. All right, so mechanism of breathing. Think of so this is all about understanding. If you can understand this, it can help you answer the questions quite easily. Think of your lung like a little balloon. and it inflating. So the diaphragm helps. So the diaphragm comes down and flattens to allow for expansion at the bottom. And the external intercostal muscles pull up your ribs to expand it like that. So the diaphragm pulls it down and that pulls it up like that to increase the volume of the lung. Now, if you remember this law from physiology, which was Boyle's law, which said P1 V1 over T1 equals P2 V2 over T2, which pretty much means that on both sides of like a something, the pressure and volume are going to be in equilibrium. So if we increase the volume, what we are henceforth doing is we're decreasing the pressure, and then air likes to flow from high pressure on the outside inside towards the low pressure. And that's what inspiration is. And expiration is just the opposite of that. And that's the first important principle. And also, by doing so, what happens is there's this baseline intrapulmonary pressure. When your lung expands, it reduces that. So what happens is the air tries to come in to get back to that pressure, but because the way our body works, it just goes a little bit over, and then our body tries to take that out. And then we are in this endless cycle of what we call tidal breathing. And another important pressure over here is this intrapleural pressure, the pressure that keeps your lung open or patent. So the pressure between the visceral and parietal pleura is minus 4 milligrams or 4 millimeters of mercury. And this is because if that wasn't the case, there's another law here. I know so many laws. Law of Laplace states because there's blood surrounding the alveoli, it would pretty much crush the alveoli. But this negative pressure allows the alveoli to stay patent and allows it to expand even more when there's air coming in. Oh. So in terms of knowing each pressure in the lung, you just need to know that the atmospheric pressure is 760. So you just need to know that in comparison to that, intrapleural pressure is minus 4. They just think of atmospheric as 0 in your questions. Just know intrapleural pressure is minus 4. And there's going to be a little bit of a change, like about 1 to 2 of the lungs opening and then closing, or like inspiring and expiring. Like that's all the values. It's nothing crazy. Now the other one is now that air that was coming in, like how the airflow of that lung is affected. So for a lung to open up, we need to think about a lung like an elastic balloon, and we need to think about how that elastic balloon opens up. So there's two things that can affect that, like that compliance of that lung. First is how stiff that material of that balloon is, like how stiff that lung is. And if that lung becomes too stiff, you get something called interstitial fibrosis. That's like a condition. Oh, I'm just using them for understanding. They don't really care about you knowing the laws. To be fair, I actually did not understand the laws back in second year, but I found that while preparing this presentation, using the laws makes sense, just knowing this brief, like understanding about them. But like, you don't need to go into too much detail about them. If you can just understand that there's that change in pressure that causes your lung to open up and your lung to open up. So the change in pressure allows air to come in. That's all that will help you to that's all you need pretty much. Now, the next thing about this compliance of the lung is surface tension, because after all, that blood has water, has fluids in it. So how are you going to keep that alveoli open? It's because of this something called surfactant, which that type 2 pneumocyte we mentioned earlier secretes. And so this surfactant reduces this surface tension and allows it for it to stay open. Now, that 25 weeks of gestation, when you form your respiratory bronchioles, the formation of respiratory bronchioles has type 2 pneumocytes in them, and they produce surfactant. That's why before 25 weeks of gestation, you can't open your alveoli. because there's so much resistance for them to open up because of that surface tension being present in the area. Now, the other way about airway, the other thing you need to think about is the air you breathe and where it's coming from. So there's airway resistance. So think about your air flowing normally, like normal breaths, like laminar flow, or you can think about it as turbulent flow, like a turbulence in an airplane, like you have shaky air coming in. And that can really affect on how well your lung opens up. The other thing is the radius of the airway, which is quite important if you think about it, because if you halve the radius of an airway, you increase the resistance by 16 times. And this is kind of what the issue is in an obstructive lung pattern, where you reduce the airway and therefore you create so much resistance for air to come in and out. More on obstructive lung diseases later on, but this helps introduce obstructive lung diseases to you quite well, is spirometry. I know this is quite self-explanatory, but I'm just going to go through it very quickly. So this is your tidal volume. This is like your regular breathing, like in, out, in, out. Now, if you get a patient to breathe out and then and just after the breathe out, take a deep breath in, that's their inspiratory reserve volume. And then you get them to take out a big breath, like go after that big breath in, that's the expiratory reserve volume. And then there's always going to be this amount of volume in your lungs present that's not going to be changed. It's just going to be there. And that's like dead space, or we like to call it residual volume. And this is quite self-explanatory. Like they're not going to ask you too many questions about this. They might get you to calculate one of like an FVC or like an FEV, but like they'll give you all the values and it's pretty easy to calculate. Now, the other thing about this whole spirometry stuff is like knowing why this spirometry stuff is important. So there's two major types of conditions. You have your obstructive conditions and your restrictive conditions. A normal FEV1 over FVC, which is your functional vital capacity and forced expiratory volume in the first go, they have this like ratio. And if it's greater than 80%, it's normal. Now, I'll actually talk about restrictive first, because in restrictive, they have a normal FEV, they have a normal ratio, but the amount of air, the functional vital capacity that they have is reduced. So they pretty much can't take in enough air, but the amount of air they can throw out is perfectly fine. So they just think about the fact that they can just breathe in less and breathe in out less. They can breathe in less, and they breathe in less, and then they just take out that same amount. So for them, it looks normal, but it's not normal because overall they're breathing in less. Whereas an obstructive, what the issue is, they can take in breath, but they can't throw it out properly. And so another important aspect over here is if you give them a short-acting beta agonist or like a SABA and it gets improved, it's asthma. But if it doesn't get improved after 15, 20 minutes and like you do the same test and it doesn't get improved, it's COPD. Another key thing to note is asthma is generally like a kid or something because it's more reversible, whereas COPD is some like old bloke after like 30 years of smoking. So it's irreversible. And so that's why something like a short acting, obviously in the name itself, won't like reverse the effects of something that you did to your lungs over 30 years of time. Now, more about spirometry. I know there's so much about spirometry. There's another table that explains those obstructive and restrictive patterns. So you have these things called, you also have these peak flow curves. And so a normal person's looks like that. Yeah. Just remember, they won't get you to like calculate values from this. What they're going to ask you to figure out is whether it's reduced overall, like restriction, or whether it has coving, which is like they're having problem breathing it out properly. And this coving is a sign of obstruction, and this reduced is a sign of restriction. And when they have both, it's like severe obstruction. And this is like your classic asthma example. This is like really, really severe COPD. And then this is like this is like interstitial lung disease. And that's quite important because that's quite a bit of chunk there that they're going to definitely ask you a question on, and quite a major focus of physiology as well for you guys. Now, the next thing is ventilation. So there's this law, Fick's law. Sadly, you have to memorize Fick's law. With Fick's law, the major things is, and why it's important is, if you reduce the area of alveoli that can take in air, but by like pretty much destroying the alveolar structure, so you're reducing the amount of surface area of alveoli present, you're pretty much causing a reduce in the diffusion of oxygen from the outside air to the inside part of your body. And this is caused by stuff like emphysema and COPD, and like and the next type of thing is where the thickness is affected. And this is where like there's fluid in the interstitium, like pulmonary edema, or you have thickening of the alveolar membrane, like pulmonary fibrosis. In either case, there's less oxygen coming into you, and you have a problem with your ventilation, because ventilation is all about getting in oxygen, getting in that air. Now, in oxygen and carbon dioxide, the partial pressures, the stuff that you need to memorize, like the least amount of stuff that you need to memorize, is just given over here for you guys. This noise I just added because it tells you what's like the outside air pretty much. But all you need to know is when your oxygen saturation at the alveoli, it is dropping to like 60 million moles of mercury, or when your oxygen saturation is at 90%, you're in a state called hypoxia. Hypoxia meaning low oxygen. So that means you're not getting enough oxygen. And these little values over here, like you have a partial pressure of 100 at the alveoli and 4 of oxygen at the alveoli, and partial pressure of 40 of CO2 at the alveoli. Kind of something that you actually have to memorize. I hate to say this. The next thing is perfusion. So perfusion is the amount, is like the blood coming to the area. And so I'm just going to correct that right now. For effective diffusion of air to occur, your perfusion and your ventilation must match. Like the amount of air and oxygen coming in and the amount of blood you're giving to that area should be equal. Now, a good VQ ratio, like we're taught, is 0.8, because you have 4 liters of air coming in per minute and you have 5 liters of blood coming in per minute. Now, there's a slinky example which explains on the next slide on why there's slightly different VQ ratios in different parts of the lung. But 2 concepts that you need to understand over here is shunting and dead space. So shunting is when there's no air coming there, and so there's a less than 0.8 VQ ratio because there's low ventilation in the area, like pneumonia and asthma. So there's some sort of consolidation there or some sort of obstruction in the airway, and there's no air not coming there. Now, the other type of case is dead space, when there's air going there, but there's no blood coming to the area. So you have like a blood clot, like pulmonary embolism. So that's dead space. So these two VQ mismatches are quite important to remember, shunting and dead space, because there can be very, very easy multiple choice questions. Now with pulmonary embolism, I'm just trying to understand pulmonary ventilation. Sorry, just trying to understand that the lungs are elastic and they're like affected by the force of gravity, like a slinky, like you have it pulled down like that slightly. So the upper parts of the alveoli are always, upper parts of the lung are always pulled down more. So the alveoli are always slightly more open, but there's just air there. Whereas the ones at the bottom are less inflated, you can say. So what happens is after that is you can get the lung to open up quite more at the bottom, and you want the lung to open up quite more so that you have more air flowing in the area. And then the good thing about that is blood also is more concentrated at the bottom of the lung due to gravity. So there's more ventilation and more perfusion at the bottom of the lung. So there's a better ventilation perfusion match at the bottom of the lung compared to the top of the lung, because at the top of the lung you have just air present, you have like some dead air present there and only very little movement of the alveoli. And the blood also has to go against gravity as well. And so this explanation that I've written on the thing explains it quite well. And the two things to note from here is you have more dead space on the top. So you're more likely to get an infection up there because like there's just like a good breeding ground for like pneumonia and like other stuff. Yeah, I think that's it from that one. Now, ventilation, perfusion, homeostasis. So the important thing to note about this is the thing that's happening second to second. This isn't for like permanent stuff. This is for like second to second, like homeostasis. So the thing that you need to know about this is it's all affected by local stuff. So let's say you had a pulmonary embolism. You had decreased blood flow to an area. So now you're going to have reduced partial pressure of oxygen in the blood vessels, and your pulmonary vessels are going to constrict. This is going to reduce the amount of blood flow in that area. And you're going to think, wow, well, this is counterintuitive. Why wouldn't you want to be pushing more blood there so that you can get rid of that stuff? Well, the point is the lung goes into survival mechanism and it just wants to like focus its energy on the stuff that's working. Like, think about it. Like if your one hand stops working, you still have the other hand. You're going to try put more effort and learn more things to do with just one hand. You're not going to try you're not going to try waste your energy on that left hand because your right hand's working. Similarly, the lung focuses its energy on stuff that's working. And so that's why it reduces the amount of air, or reduces the amount of blood, or increases its amount of air and increases the amount of blood to wherever needed. Now, with this ventilation perfusion mismatch, so as you can see there, so the top shows ventilation. You see with oxygen, there's air everywhere. But in the perfusion scan at the bottom, you see that there's missing areas where they're not getting perfused. And so this is a sign of a pulmonary embolism. And that same thing can be seen on that CT here with that big fat embolism over there, marked with the arrow. Now you have another type of test. We went through the spirometry test earlier. Now there's another type of test, your TLCO and DLCO. This pretty much measures how well gases travel across the alveolar capillary membrane, that 5-6 layers that we talked about earlier. You get the patient to breathe out, and then you get them to breathe in some special air, and you measure the exhalation straight after that to see how much they like breathe properly. And so in asthma, it would be normal because it's an upper airway stuff. It's not down at the alveolar level. Whereas in COPD, you kind of have destroyed those alveoli. So you have less of those alveoli present. So in this test, you're going to have a reduced result. In fibrotic changes as well, you're going to have a reduced result because you have fibrosed areas. So you have less patent bronchioles in the area as well. So this is the only place where asthma is going to be normal. Everything else, you're going to kind of see a change here. Also, if it's a chest wall deformity and you know it's a restrictive pattern, you'll see a normal TLCO as well, because it's again like a more upper airway type of thing, not a lower airway thing, not like at the cellular level, you could say. The next thing is transport of gases. Pretty much, you have like these 0.25 seconds for that blood to flow through a single alveoli. And it gives you enough time to exchange oxygen and carbon dioxide between the two areas. And that's all you really need to know from this stuff, like from the transport of gases. The next stuff is your hemoglobin and oxygen dissociation curve. So from this, what you need to know is how to read this diagram first. So that state where we said someone was hypoxic, finally, so it's 60 millimoles of mercury is their pressure. So you see they're at 90% oxygen saturation. There's a couple of values that you kind of need to memorize. But what happens is after 40, then you see a massive dip, because hemoglobin has its tendency. If you have an oxygen present there, it has a higher affinity to bind to even more oxygen molecules. If it has less oxygens, it's less likely to bind. I don't know. Hemoglobin's a moody person. It's if it hangs out with one of the oxygen, it wants to hang out with all of them. That's kind of its deal. You can think about it that way. So another thing about this curve is it can shift to the right or the left. And when it shifts to the right, it has reduced affinity. So what it does is it allows oxygen to offload onto tissues better. And this is classically seen when you're doing more exercise. You have like more CO2, you're having lactic acid buildup. So you're becoming more acidic in the area. So you're shifting to the right. You're also increasing your body temperature, everything pointing to the right. And then these are like the things that you need to remember is with increased temperature, increased this enzyme and and when you have an increased acidity, it shifts to the right. This is quite core stuff that you need to memorize to understand how this hemoglobin oxidation curve works. Because the question is, is this person fit for ICU? Well, they're hitting that 60 now. They're hitting that 90% now. So we should. But what if that person was exercising? Well, maybe their levels now earlier because this curve shifted to the right. So stuff like that pretty much is what they're kind of going to be assessing you on in this. I know physiology is quite a bit like extensive in respiratory, but we're almost at the end of it. Now, how are you going to control all of this ventilation? So for neural, it's the neural stuff controls autonomic rhythm and modulation, and chemical, the chemoreceptors control the modulation of rhythm as well. So in the neural control, the medulla has this pre-Bodzinger complex in the ventral respiratory group, which is the pacemaker of your unconscious breathing. Like your heart cells have pacemaker, the brain has like this pacemaker of your breathing. From there, the signal goes to the dorsal respiratory group, then your diaphragm to inspire. Your pons also has an area which is called the pneumotaxic center, which is responsible for stopping your breathing. Along with this, your cranial nerve 10 and 11 act at your ventral respiratory group to modulate your rhythm. And they're different these are like different responses that show their effect on breathing. I would say have a quick read of this in your own time. I'm not going to sit through here and tell you like each of the different responses, but pretty much if there's stretch receptors in your lung being like, oh, we're stretching too much, it's going to be like, all right, stop breathing less now. So it's all like your feedback mechanism. Now, moving on to the chemical control, there's two forms, your central and peripheral. So central is at your brain level. This is located in the medulla. It acts way slower, but it accounts for like the majority of the changes. And this is monitored by the CO2. This monitors CO2 via H+, because the CO2 combines with water to become H+ and carbonic acid, and it measures that H+ rise. The key thing to note here is your brain has pH receptors. It does not actually measure the amount of carbon dioxide. It measures the carbon dioxide indirectly via the H+. And in the peripheral, now moving on to the peripheral control of the ventilation in the chemical side of things, it's located in the carotid bodies and the aortic arch. It acts faster and has a smaller effect, and it monitors the oxygen, carbon dioxide, and the H+. Now, there's a couple of extra things here. So the gases in the blood. So carbon monoxide has 250 times more greater affinity for oxygen than hemoglobin. So very, very tiny amounts, like 0.4 millimoles of mercury of carbon dioxide is gonna compete with like 80, 90 millimoles of mercury of oxygen for the same hemoglobin molecule. And so the treatment for this is removal from the area and increasing the oxygen supply to help overcome it. Next, at high altitudes, sometimes people hyperventilate. They do very fast and shallow breaths. And this leads them to lose too much carbon dioxide, and they become hypocapnic. This is just like a fancy word which says low arterial carbon dioxide. And the treatment for this is you give them a rebreathing device or you get them to blow into a bag. When someone has a panic attack, this is another case where they can become hypocapnic because they're hyperventilating. So you want them to blow into the bag, like that classic scenario. Sorry, guys. I think someone just, sorry, give me 1 second.
All good, Jasmine?
Give me 1 second. Someone just rang my doorbell. Give me 1 second. Yeah, sorry guys, I'm back. The TNT guy gave you like a little like 2-minute break, I could say. So the peripheral chemical control is controlled by carbon dioxide levels, oxygen levels, and also by the concentration of the H plus. So it's a triple whammy. So it gets controlled by all three of them actually. So the chemoreceptors there are much better than the ones in the brain, because the ones in the brain, I don't know if they're all equally important actually. I don't think we were told about that. We were just told that all you need to know from the feedback mechanism is that. I know you guys had like full lecture on like both these topics together, but in saying that, all you need to know is literally just these 2 slides. Because I remember only like one question coming up about this, and the question that they did ask was whether, like, what do you measure in the brain? And it's always H plus because they have pH receptors. I think that's actually kind of like the more important one, you could say, because that's the only thing in the central side, whereas in the peripheral side, it's all 3 of them. So I wouldn't bother too much about that. Now, moving on to the pharmacology and microbiome. So most upper respiratory and lower respiratory tract infections are viral. So you treat them symptomatically, such as oxygen therapy, corticosteroids to assist with the breathing. Now, in these viral cases, if they become severe, you want to treat them with like an IV, like an aciclovir or something like that. If they get a bacterial infection in like a community-acquired pneumonia or a hospital-acquired pneumonia, you're now a bit more concerned, because in a viral infection, they're going to have like a low-lying temperature, whereas in a bacterial infection, you're going to see like these high blazing temperatures. Like that's a very good sign. Like if you see like a slight raise, think viral. It's like dipping in and out, kind of viral. If they have like proper fever, you're thinking like something bacterial. That's a good way to think about it at your level. The other thing is, the general principle is, if it's bacterial, you treat them broad spectrum. Like if it's mild pneumonia, you go for amoxicillin. If it's moderate pneumonia, you go for something more severe like a ceftriaxone. If it's like something very severe, you're going to go for like doxycycline plus something else. Like you're going to go up the chain. So you're going to go empirical therapies until you get back a result. That's sort of what the process of going about picking your antibiotics for this stuff is. Now, the extra one that you need to know about is TB. And the TB is like your RIPE, which I'm sure you did in first year. I don't even think I spelled the spelling of isocyanide correctly, which shows you how many times I've come across this. So rifampicin and isocyanide are the ones that they're going to target at your year level. Yeah, thanks, Jack. Exactly. So Jack was paying attention in first year. I wasn't. So I forgot the spelling for that one. But this is a cute little summary table, which you can thank PS I Miss Pre-Clean for. So Karan in the year level above made this lovely table, which shows you like the key buzzwordy features of each of the conditions and the treatment that you should do for them. Like rhinitis is like your common cold, classically viral, nothing to worry about. If you get a kid with a ear infection, it's acute otitis media. You're gonna give them amoxicillin as like your first line. So very, very basic stuff. The other one is that you need to know about for sure is pneumonia. Pneumonia treatment depends on what they have, so you don't worry about too much about that. Like they won't get you to treat pneumonia. TB is another one that they definitely will ask you about, and so you need to know that. See, isoniazide, like the spelling over here is correct. So that ripe treatment, you should know about that. And influenza is another one, but only when necessary. Like if it's a severe influenza, like yes, you're going to give them oseltamivir or acyclovir. Like otherwise, you're not going to think about your antiviral therapies. So this summary table is quite good for like combining microbiome along with your antimicrobials in like a 2-table summary. The next thing is asthma versus COPD. Now this, I know you guys would have gone through in severe detail in like your lectures. But the key thing is asthma is reversible obstruction. COPD is irreversible. Asthma is an inflammatory disease and it's caused by your T helper cells. Think of allergic reactions or helminth infections as your buzzwords. And they cause bronchospasm. Whereas in COPD, you have this alpha-1 antitrypsin, which is now deficient. And that's a problem because your lung white blood cells, when they fight infection, they produce proteases. And that proteases actually now start self-damaging and cause the alveoli to get destroyed. And the alpha-1 antitrypsin not being there is allowing this destruction to occur. In asthma, your airway is hyper-responsive, and that's what leads to the bronchoconstriction. Whereas in COPD, you have a range. You like start off with the narrowing of the lumen, and then which is chronic bronchitis, and you finally end up with emphysema, which is like destruction of your alveoli. Now with asthma, your classic symptoms that they will be going after is wheeze, cough, shortness of breath, allergic trigger, and triggered by like stuff like aspirin, beta blockers, and exercise. Like these are like 3 things that is like a very pharmacological type of thing. Like, oh, what's a respiratory condition that you can get from allergy from beta block, or when someone took too many beta blockers, you're hearing an expiratory wheeze. Well, expiratory wheeze will tell you it's an asthma. But in case you were like trying to wonder, beta blockers can cause asthma as well as a complication. Oh, sorry, as a side effect, not a complication. What am I saying? And in COPD, you have your chronic cough. The word chronic is quite important here because COPD is chronic obstructive pulmonary disease. You have your worsening shortness of breath. They have barrel chest. You'll see use of their accessory muscles as well. And they have something called like a tripod position where they go like that, hunch, and they'll try really hard to breathe. And these people generally have a smoking history as well. Now, another difference which I mentioned during spirometry was that you'll observe a difference with bronchodilators in asthma by 12% or more, whereas in COPD, you won't see that difference. The next thing is the treatment about this stuff, because that's the other pharmacological topic that you need to know about is asthma and COPD. COPD, you have an alpha-1 protease inhibitor, which works in a similar way to alpha-1 trypsin, and you just give them that, all good. They get a bunch of other stuff. You need to know, you don't need to worry about that too much. For asthma, there's like treatment stages. So initially they get So the treatment stages are SABA, LABA, SAMA, LAMA, ICS, and big boy stuff. The big boy stuff is stuff that you shouldn't worry about too much because by that point they're with a respiratory physician. But a SABA is a beta 2 agonist that you use to target like the immediate acute phase of their asthma by relieving that bronchospasm. Your classic drug example is salbutamol or generic name Ventolin, and it's mainly used for like exercise-induced asthma. The next one is your LABA or your long-acting beta agonist, used to target like the late chronic phase of asthma by trying to reduce that inflammation. Salmeterol or anything that ends in eterol is usually a LABA, and it's used for nocturnal asthma and is used in addition to steroids. So you don't have to give too much steroids because steroids have like tons and tons of side effects, which LABAs don't have in comparison as much. The next thing is SAMAs and LAMAs, which are your muscarinic antagonists, short acting and long acting, and they pretty much reduce mucosal secretions. The ones that you need to know are the SAMA is the apratropium and LAMA is tiotropium. If it's a tropium, it is a muscarinic antagonist. That's what you can think about it. And M3 muscarinic antagonist is like specific to the lung as well. It's like targeting the lung for sure. And this is all inhalation stuff, by the way. Everything that we've talked about so far is all inhalers. These are all on your e-pharmacology as well, so that you definitely need to know these. The next type of drug you have is your inhaled corticosteroids and oral corticosteroids, and they don't have any immediate effects. They only have long-term effects, but they also have a bunch of side effects like thrush, dysphonia, thinning of skin. And the ones that you need to know are budesonide and fluticasone. And the problem with these drugs is because they don't have immediate effects and they have a bunch of side effects, people hate taking these drugs, so they have low compliance. The other thing is your big boy stuff, like the ones that end in luzumab. By this point, this person is with a respiratory physician. Like, you're not worrying about treating them. Like, at this point, they're definitely with a respiratory physician. But I'm pretty sure they have one luzumab drug in your e-pharmacology. So that's why you should be aware of it. And it's like the final stage. Now, finally, you have clinical skills. So this is from your respiratory SIP. I think one of you guys actually made this whole table in Excel, which was lovely, I think. I would definitely say look at it, give it a proper read, because the history and exam they're giving you, and then the what's it called? The epidemiology that they're giving you is very, very typical of Monash. Like, they love giving their buzzwords, and it's a great summary of the conditions as well. Now, I'm going to go through a bunch of the physical examination signs quickly and history stuff to help you guys understand it a little bit better, like just simplifying a couple of words. Styria means like fatty diarrhea. Finger clubbing is a sign of hypoxia. It's not a respiratory sign of CF or anything else. Finger clubbing is just you're not getting enough oxygen, hypoxia. That's all this is. The next one is crackles. So the one more thing I would add to this is interstitial lung disease. You hear fine crackles because it's a fibrotic thing. Fine for fibrotic, that's how I remember. And then coarse crackles is stuff that you hear with fluids, because in this case, in pleural effusion, you'll hear coarse crackles. In pulmonary edema, you'll hear coarse crackles. In right heart failure, you'll hear coarse crackles. So anything with a bunch of fluid in the lungs, you're going to hear coarse crackles. Now, obstructive sleep apnea is this one condition that if you just read everything along this line, it literally covers everything that you need to know. And I think even that's like more than enough detail for you guys. And the pharmacology, like the modafinil, anything like that, is all this stuff that is used like along with CPAP to help figure out with obstructive sleep apnea. Plural effusion are quite straightforward, actually. Yeah. All right. What I'm going to do is I'm actually going to let you guys read through this in your own time. If there's any particular sign that you guys don't understand, feel free to ask me, or any like physical exam or history sign, just put it up in the chat. I'll explain it quickly. Another one that I just want to mention is cachexia. Cachexia is important, which is like wasting, muscle wasting, like because you're not using those muscles. But yeah, it's like this general sense of wasting. But yeah, I don't think you know what? I think I'm gonna leave it there and I'm gonna move on to questions now. Because these EMQ questions are straight up from the thing. Are straight up past exam questions, most of them. So it'd be fun to see what you guys answer for these ones. Just message your answers. So it's a 45-year-old male and they have an acute onset of shortness of breath. So think of something acute, like something that just suddenly happened. PE. Yep, good work. So it's a PE, correct. The answer is 8, PE. It's a PE because the buzzword here is they had a surgery last week. So they have a high risk of clotting and they have this sudden pain upon inspiration. So it's all like tying up to a picture of a PE because it happened all of a sudden. They had a surgery. They're probably sitting on their ass. Everything signs of a PE. The next one. It's a 26-year-old male complaining of recent episodes of non-productive cough, chest tightness, and shortness of breath on exertional. There's no known trigger. He has a family history of hypertension and type 1 diabetes. Anyone? Guys, just take a guess. Even if you get it wrong, I don't care. Yeah, asthma. Perfect. So this one is more like hypertension, type 1 diabetes, like they have autoimmune stuff running in their family. Plus, it's a young person with a non-productive cough. So there's no phlegm, there's nothing. It's a dry, non-productive cough. And they have pleuritic chest pain, everything pointing to an asthma. Yep, asthma, perfect. Next is a 70-year-old male with a 30-pack history of smoking, presents to their GP with worsening shortness of breath. 4, yep, the person who called pulmonary. That was really fast, actually, really well done. So called pulmonary is right-sided heart failure. And in this case, this was like a little bit of like a mixed bag because this person has other signs like ascites, pedal edema, and JVP, which all shows like right atrium backlog. Like there's problem of like fluid collecting behind it. So there's multiple areas. There's not like a single thing. So that's why the stem was the important part in this one, because people would have jumped to COPD because of his smoking history. So that's why this was there. The next one, productive cough, chest tightness, and fever. 7, pneumonia. Okay, why did you pick pneumonia and not TB? What's the reason behind that? Can anyone answer? Just unmute your mic and answer if you can. Or type it in the chat.
TB isn't an option.
Pulmonary tuberculosis is an option. It's number 5. Does that change your answer now?
Yep.
Is it TB now?
No.
No. Okay, so why is it not TB and why is it pneumonia?
Productive cough.
Yeah, okay. So I'll give you a hint on this. So with pneumonia, it's a very pathognomonic thing that it's someone coming from like a Asian country or coming from Asia or Africa. Like it's not something that we're gonna see over here. And we're very good. Yeah, why it's not TB, sorry, my bad. Why it's not TB is because it's a very like pathognomonic thing of someone coming from Asia or Africa. And the other thing is it's you'll see a question which I put on later purposely to show you what a classic TB presentation looks like. But yeah, this is correct. This is pneumonia. So this was one of those like eliminate your options and pick your answer. Ooh, I don't know why I said 9 over here. My bad. I don't know why this keeps happening. 7. Yeah. Sorry about that. We'll change that in the slides later. We have 2 questions together. So there's a 34-year-old man who presents to his primary care physician with a 7-week history of hemoptysis. He's had a poor appetite during this time and notes that his clothes are loose on him. Yeah, is TB, yes, because hemoptysis. So hemoptysis is seen in 2 cases where it's lung carcinoma and TB. So D was missing that hemoptysis thing. It's like very, very classic differentiation between pneumonia and TB would be that TB has hemoptysis and that doesn't. The other thing is he felt febrile sometimes, but it wasn't like, but felt febrile at times. So that means he was going up and down. It was like a very slow thing. It wasn't like a very high fever. It was very like a light fever. And that's another thing about TB as well. So it will show viral patterns as well. All right, the next one, F. A 68-year-old female presents with cough and shortness of breath lasting 2 weeks. Yep. Who, Alex, hemothorax, no, sadly. This is pulmonary edema. So pink and frothy is a very classic pulmonary edema thing. And so it's a very like buzzword mnemonic thing, which is pulmonary edema. Yep. Alrighty. Sorry about that. There's nothing else I could say about that. The other thing with hemothorax is think of something traumatic. Like the person didn't have anything traumatic. It lasted for 2 weeks. That's another thing that gives you a hint that can be a hemothorax. Yes, correct. A footy player was kicking a goal and he got a sudden sharp chest pain, tension pneumothorax. It's always a sports player and it's very sudden. So, oh my God. I think I messed up my own numbers. I'm so sorry about that, guys. We're going to change that in the final slides. Another note for exams is make sure you pick the right number or letter. Don't do what I am doing right now. So meniscus sign is something that is shown for a pleural effusion. For sure. Actually, yeah, wait, 9 was. Actually, no, that is a spontaneous pneumothorax. You're right. Sorry. I didn't read my own options. Yeah. 9 would be a spontaneous pneumothorax, not a tension pneumothorax. Yeah. Sorry, I read it like 11 as 9. My bad.
Can you explain the difference between the tension and non-tension pneumothorax?
Between a tension and a non-tension pneumothorax. So I think from my understanding, I think one of them is like if you have something. Oh wait, I actually might have to get back to you on this later.
I think I might be able to answer it very briefly.
I can sub in as well if necessary. A spontaneous pneumothorax only occurs in very rare circumstances, or only if you just barely pierce the.
Yeah, that's what I remember.
Barely pierce the pleura. Whereas a tension pneumothorax occurs in a traumatic event when there's air coming in and it's unable to escape, and that's why you get the other symptoms like deviation away from it and air coming in and staying in. There's no, it's just a spontaneous pneumothorax is a collapsed lung, while tension pneumothorax is like one that's filled with air.
Yeah, because I remember tension pneumothorax, it's like, for example, if you get like a knife stabbing, that's how I remember it as well. If you get a knife stabbed, so the air came in from the knife, but it stayed there, like you haven't pulled out the knife. Is that an example? Yeah, so it's a spontaneous pneumothorax because there's no mention of trauma there. Sorry about that mix-up, guys. Finally, a concerned baby's parents brought him to the GP because he kept on getting recurrent chest infections and he's underweight. And he's also of Caucasian. Yep, CF. Perfect. All right, guys, that's the end of the presentation. Any questions, people? Thanks for answering that question, by the way, Jack.